Estamos muy contentos de empezar ahora más una sesión NASPGHAN visitando LASPGHAN. Tenemos este mes de abril 4 sesiones. La primera será con el doctor Glen Furuta. Yo me gustaría de introducir la señorita Han Vo, is chair of NASPGHAN International Committee, and she is going to introduce Dr. Glen Furuta for this talk.
Good evening, everyone, and thank you, Dr. Spolidoro, for the introduction. And again, welcome you on to the second NASPGHAN Visits LASPGHAN webinar series. We particularly thank the NASPGHAN and LASPGHAN leadership for supporting this educational event, especially our LASPGHAN colleagues for the collaboration. We also thankful to all invited speakers for sharing knowledge and expertise, especially the LASPGHAN technical team for making this webinar series possible. Tonight, we look forward to listening to Dr. Furuta sharing his expertise in eosinophilic esophagitis, and we hope you will enjoy this webinar. Thank you.
Dr. Furuta, we are going to present your record, and afterwards we can have some questions if you can be with us. Okay?
Thank you. I'll look forward to that.
All right.
Good afternoon and greetings from the Children's Hospital of Colorado, University of Colorado, and the Anschutz Medical Campus. It's a pleasure to be here today to speak to you on eosinophilic esophagitis, the current and future management. I wanted to start my presentation to you today with this one non-eosinophilic esophagitis slide that shows a new nomenclature for eosinophilic GI diseases. This was published last year, and the primary lesson to take away from this is the fact that all of the eosinophilic GI diseases will have different terminologies so that they are eosinophilic, followed by the organ with the most infiltration. And shown here in the middle, eosinophilic esophagitis, eosinophilic gastritis, enteritis, and colitis, all with EO as a prefix. It is also a note to say that there is an upcoming LASPGHAN EACHA guideline that will be coming soon. There was participation from our Latin as well as our Asian colleagues in the development of this. Well, let me start with two case histories. The first is a 3-year-old picky eater, a male patient who had never been a good eater, had always been very picky. He had vomited several times a week, and his parents reported very long meal times that resulted in family discord. He had a history of allergies, and his growth was on the lower percentiles, but following along a curve. The second patient is a 17-year-old, the fearful carnivore, again, a male patient who presented to your office who had food stuck while eating a steak dinner, had a history of asthma and allergies, had reported that he had had foods getting stuck for a number of years, but had not told his parents about it. And his parents report that he always took a large bite, but seemed to eat too fast. We'll return to these two patients at the end of my presentation. Just to review the pathophysiology of eosinophilic esophagitis in the genetically predisposed patients, allergens can contact the esophageal mucosa, thus leading to the influx of eosinophils by virtue of a number of different processes that can lead to esophageal remodeling with a small caliber esophagus, longitudinal shearing, inflammation, and in some patients, fibrosis with stricture formation and dysmotility. Today, we'll be talking about two different areas. The current management, we're reviewing the diet as well as the medical and what's available presently, and we'll talk a little bit about the future. And this publication that came out about 2 years ago about where are we today with our colleagues in South America, with Dr. Targa and Vieira, really helps to point out, again, the fact that EOE is a chronic esophageal inflammatory disease. An important concept to remember as we think about the goals of treatment. They're not only to improve symptoms, not only to maintain growth and development, to prevent complications, and as we do this, now balancing out the risk and benefits of the treatment with the quality of life. What are those complications associated with EOE? They can include esophageal stricture, food or foreign body impactions, and in severe circumstances, potentially feeding dysfunction with slowed growth. On the right-hand side, you can see the endoscopic appearance of a mild inflammation, perhaps a little bit more inflammation, and increased inflammation that can occur over time. And this inflammatory process may result in fibrosis, changing from diet therapy to needing dilation along that spectrum over the natural history. If we think about how we consider and assess disease activities, certainly we think about symptoms. In the middle, thinking about histologic activity with eosinophilia, but also other different forms of inflammation in the epithelium, and then endoscopic activity. And each of these boxes are represented here into separate domains. If there is no response to treatment, complete response, it may not fit into any of these categories. And if it were to fit in all of them, we could have potentially a complete response. And I bring this up to you because of recent work that has been done to develop a clinical disease severity index, or the index of severity of EOE, the IC, that was developed as a result of a longstanding efforts by the American Gastroenterological Association. And in this publication, there is a chart, a table shown here, in which each feature of EOE, the symptoms and complications, the inflammatory features, either endoscopic or histologic, and evidence of fibrostenosis are provided points across the top. And here is a patient, much like the one I presented to you, that had symptoms of disruption multiple times a day, diffuse inflammatory features, and evidence of fibrostenosis, with a score of 11, having moderately active. And this score, it is hoped that will provide us a way of tracking disease activity over time and hopefully will help to guide therapy. Well, is it in fact true that therapy can impact the natural history of disease? And here is evidence from the Swiss group, which has the longest standing studies on natural history, in which they performed a retrospective study, analyzed over 200 adults over 5 years, and looked on the y-axis of the percent of food bolus infection in patients who were either untreated or treated with increasing amounts of topical steroids. And I think what you can appreciate is the fact that patients who had more treatment and longer treatment had reduced impact in incidence of food impaction. Likewise, when the same type of study was done in the Swiss group, when you looked at the percent of patients in remission over time and years, you can see that if there was closer follow-up, there was a sooner induction of remission as opposed to those who did not have long follow-up. And on the far right-hand side, one can see that those patients who had less follow-up and less treatment had more incidence of stricture formation. So this is a way of saying that the treatment that we'll discuss does make a difference in overall outcomes. In thinking again about the pathophysiology of this disease, food allergens contact the epithelial space. In the epithelium, there is the induction of release of inflammatory proteins shown here that can bind to different cellular receptors and then cause the influx or activation of a variety of immune cell populations, leading to esophageal dysfunction taking the form of inflammation, laminar propria fibrosis, dysmotility, and in some cases, potentially loss of epithelial permeability. Let's turn now to dietary management, probably one of the first forms of therapy that were noted for eosinophilic esophagitis. Here's a really nice timeline showing that initial actual not only identification of treatment, but some of the first children who had eosinophilic esophagitis, noted by Kelly and Sampson in 1995, in which they treated 13 patients with an elemental diet, showing that they were had a diet Inflammation was reduced and successful induction of treatment. Following this, Jonathan Spergel, as well as Amir Kagawala, formed many of the initial studies looking again at children, the removal of foods by a variety of different techniques, and showed that this indeed also was impactful for the induction of remission in eosinophilic esophagitis. And then most recently, we have seen in a number of studies in adult patients, and we'll review these to show that likewise, removal of allergens in adults can lead to remission of EOE. These are, I'll show two slides that summarize the AGA's guidelines on the management of eosinophilic esophagitis that were published in 2020. And in fact, these have already, I think, probably need to be updated on the basis of recent evidence. There were two recommendations made by the AGA. This is one that suggests that the use of 6-food elimination diet over no treatment is beneficial in patients who have eosinophilic esophagitis. Most recently, last month, was this publication from the Seeger Consortium, in which there was an objective to compare the efficacy of 6-food elimination diet versus 1-food elimination diet in adults with EOE, thinking that could this dietary approach simplify the approach to nutritional management. It was a prospective randomized multi-center study from 10 sites in the United States. Adults aged 18 to 60 years were enrolled with a primary endpoint of resolution of histologic inflammation and secondary endpoints of symptoms, endoscopic appearance, and quality of life. When one looks at the results of these studies, the bottom line was that 1 food compared to 6 food had very similar responses. So here's the summary of the 1 food, in which there was induction in histologically of 34% of patients, a reduction in symptoms, endoscopic appearance slight, and a lack of impact on quality of life. The 6-food elimination diet had very similar findings with no real statistical difference in any of these. So I think these findings suggest that eliminating animal milk alone could be an acceptable initial dietary therapy for adults with EOE. And likewise, these findings have been confirmed in children in the Bakori study shown on the left-hand side of this chart. The right-hand side shows the results of the SOFIE study, the study I just showed to you on adults. Very similar results with children, showing that whether it was 1 food or 4 food in this case, there were very similar types of responses, suggesting that perhaps dairy exclusion may be helpful in managing patients initially. Well, this shows a number of different graphs with the eosinophil numbers on the y-axis and numbers of endoscopies on the x-axis. Work from Mason Nistel in our group has shown that over a period of time, over approximately 5 years, that in fact patients can sustain a response when single foods are eliminated, and in fact have an increase in eosinophils when they are added again. So each one of these bars suggests that reduction of food can lead to induction over time. Let's turn now to topical steroids. I think we're well familiar with the fact that swallowed topical steroids are quite effective in treating patients with eosinophilic esophagitis, with ranges of 60 to 87%, depending on the study that was examined. These are typically taken twice a day, and those most commonly used include fluticasone. In our work, ciclesonide, another topical steroid with 2 puffs swallowed from the meter dose inhaler, or viscous budesonide, provided as a thick slurry developed either from Splenda or Nutra. The most recent studies, again, support the concept of using topical steroids in the treatment of patients with EOE. This is a head-to-head comparison of budesonide versus fluticasone in adult patients by Evan Dellin and colleagues, showing that there was no superiority of oral viscous budesonide, with the percent of eosinophil count in both budesonide treated as well as fluticasone treated having a significant response. when one looks at fluticasone again in an oral disintegrating tablet, not the nebulized or the aerosolized form, again, this shows that there is a successful treatment with 106 patients in this phase 2b trial using a 3 milligram tablet twice a day. And one can see that the endoscopic appearance at the beginning of treatment is significantly improved over time compared to placebo. The other forms of topical steroids with budesonide that have been provided by different kinds of vehicles, this is the suspension form of budesonide, improves both pediatric and adult EOE. In this study, children of 11 years up to adults of 55 years of age were enrolled in a randomized clinical trial to receive either budesonide or placebo. And one can see that the eosinophilia, shown here on the y-axis, was significantly improved in those treated with budesonide. And the symptoms of dysphagia likewise improved, but not to a statistically significant level. Budesonide oral dispersible tablet, or BOT, also is able to be effective in treating patients with eosinophilic esophagitis, as shown in this study of both adolescents as well as adults. When one looked at the percent of patients who were in remission overall, over time, there was a significant improvement at both doses used. Compared to placebo, when we looked at only the clinical remission, one can see that there again was statistically significant improvement, and the endoscopic appearance also showed an improvement over time. The concerns about potential of the use of topical steroids include thrush, which is seen infrequently and quite immediately after the start of the use of topical steroids, adrenal insufficiency. In our hands, about 5% of patients, all of whom were asymptomatic, and in fact, all of whom were also on other forms of topical steroids at the time of its use. And then finally, there has been a suggestion of mood changes associated with the use of these medications. The cause and effect is hard to know, but perhaps this is more frequent with the use of budesonide. Adherence has always been a question. I want to just let you know about this work that's been done by Pooja Mehta in our group that is starting to examine not only how often children and adolescents adhere to treatment, but also thinking about novel ways of improving their adherence. And in Dr. Mehta's work, she showed that there, not surprisingly, was a lower adherence in adolescents compared to young children. And in fact, when you charted this with a sensor on the meter dose inhaler versus self-report, there was a much lower adherence reported by the sensor as compared to that reported by the patient themselves. So the second guide that was provided by the AGA was that the AGA actually made its only recommendation that topical steroids should be used over no treatment. This was a strong recommendation over no treatment. How about PPIs? Well, proton pump inhibitors have had a long and storied history in the evaluation and treatment of patients with EOE. And I'll just go to state in this very nice summary by Dr. Molina Infante that proton pump inhibitors can actually be very effective in treating both children as well as adults. The authors are shown here. The doses and type of PPIs are shown here in the second column, a wide variety with differences in dosing interval, differences in duration of weeks of the different studies, and there is overall an effectiveness of histological as well as symptomatic improvement, somewhere between 25 to 69% of the time. And this does not appear to be specific for a certain PPI, and likely in work done by Rhonda Souza and Stu Speckler and their group seems to potentially impact the STAT mechanism of induction of eotaxins. The second point to remember about the proton pump inhibitors is that they are no longer a part of the diagnostic criteria. Initially, these medications were used to rule out reflux, but because of that therapeutic effect that I just shown and the basic studies that have been done that suggest a molecular mechanism, they were pulled out of the diagnostic criteria, and presently the diagnosis rests on having a clinical symptomatology suggestive of VOE, a diagnostic endoscopy with biopsy that shows increased numbers of eosinophils, and then finally ruling out other concomitant disorders that may be contributing to that eosinophilic inflammation. And that is the current diagnostic standard. Well, let's turn now to probably one of the most exciting things that have happened over the course of the history in eosinophilic esophagitis. The use of a medication called dupilumab, the trade name of Dupixent, is a fully humanized anti-IL-4 receptor antagonist antibody. So this medication is able to bind to the alpha receptor of IL-4 and thus prevent the signaling of IL-4 to the nucleus, thereby activating a number of different factors that can contribute to eosinophilic esophagitis. IL-4 and IL-13 have been associated with the dysfunction in not only EOE, but also asthma and eczema. And all this has been previous work. And this medication has been, in fact, used now for a number of years in the treatment of severe asthma as well. Scrutiny over this that was led to this case series performed by Spergel and 45 EOE patients, children who were treated both at Children's Hospital of Philadelphia as well as at Rady Children's Hospital. They had a number of other atopic conditions, and those atopic conditions led to the treatment of those with dupilumab, and that co-treatment of an allergic condition and EOE led to remission in the majority of those patients, allowing the reduction in EOE medications. One can see on the right-hand side, there was an improvement in the histology of those patients on twice daily or twice monthly treatment, improvement in the endoscopic appearance, and improvement in the symptom score, suggesting that dupilumab could be effective in the treatment of not only other atopic conditions, but also for EOE. Well, on May the 20th of last year, there was this landmark day in which the FDA in the United States approved the use of dupilumab for eosinophilic esophagitis. It was in large part supported by this study in the New England Journal of Medicine that examined the use of dupilumab in adults and adolescents with EOE. In this article, there was shown to be a histological improvement with the use of dupilumab. Compared to placebo, one can see the percentage of patients in remission shown on the y-axis. In placebo, dupilumab treated on a 300 milligram weekly basis and then treated on a biweekly basis shown here. Both of these seem to have a histological response with respect to frequency of dosing. When one looked at the symptomatic improvement, the mean change in score with the lower score, meaning there was a improvement over time, you can see that dupilumab at 300 milligrams on a weekly basis showed a significant improvement compared to placebo, but this 300 milligrams on a biweekly basis did not show the same type of response. And so the labeling for dupilumab for EOE that was provided by the FDA was for weekly dosing at 300 milligrams. The next form of IL-13 disruption is with cendakimab, in which this is an anti-IL-13 antibody which binds to IL-13, preventing the IL-13 binding to its receptor. It's highly selective, has been examined now in phase 2 clinical trials in adults and late adolescents with 2 doses, again with the mean primary endpoint of change in eosinophilia. When one looks at the symptom score on the y-axis here, you can see there's a decrease in primarily the 300 milligram dose compared to placebo and the lower dose, when one looks, as shown there, at 16 weeks, when one looks at the peak esophageal eosinophilia count in those who were treated versus a placebo, one can see that there was a marked reduction in the numbers of eosinophils seen over time at both the 180 as well as the 360 doses, and likewise an improvement in the endoscopic appearance in those treated at both doses. This has gone on to be a longer study, a maintenance study, in which patients went on to receive, who were enrolled in that 16-week study, went on to be followed for 1 year, and based on those studies, received 300 milligrams per week, again charting similar types of endpoints. One can see here the peak numbers of eosinophils at the entry into the maintenance, and there indeed was a maintenance of this lower level of eosinophils in those receiving long-term treatment, and likewise a decrease in the endoscopic appearance in those treated compared to those who were maintained on placebo. So what is the current approval use of dupilumab is for eosinophilic esophagitis in adult and pediatric patients over 12 years of age who weigh at least 40 kilograms at the dose of 300 milligrams per week. As I said, this certainly brings up a number of certainly interesting and I think exciting opportunities, but also raises some concerns and thoughts about when to use a very expensive biologic in which there may be potential long-term side effects in reductions of eosinophils, although those would be hypothetical presently and not identified clearly in any adult studies, but expensive medication, biologic. And to address this, our group has begun to start to look at those patients in whom we have treated with dupilumab. And here's the 14 patients who've been treated since May in unpublished data by Natalie Nguyen and Pooja Mehta, finding that they were either non-responsive to topical steroids, not adherent to their treatment, had potential side effects associated with their previous treatments, or had other concomitant atopic conditions. So I think the story is still out into what the long-term use of this looks like, how this will be integrated into practice, but it certainly is an exciting development in the treatment to have an approved therapy for our children and adults with eosinophilic esophagitis. Well, let's look forward to the future now. What can we anticipate going forward? And I think the development of a biologics has certainly raised a lot of hope, and I think there are other kinds of treatments that likewise may bring us new approaches to care for our patients. And let's think about what some of those new potential therapeutics could be. They're listed here, including larentelimab, or an anti-Siglec-8 antibody. It has been used in treatments for eosinophilic esophagitis as well as gastroenteritis. Benralizumab, an anti-IL-5 receptor that has been used for hypereosinophilic syndrome, and likewise ongoing studies for eosinophilic esophagitis. Tezepelumab, an anti-TSLP antibody, which is being used in a phase 3 trial for asthma, and anti-IL-3, again, a phase 2 trial for asthma. I wanted to call your attention to 3 other very interesting targets, including the etrasimod, a sphingosine-1 phosphate receptor modulator, vedolizumab, which you're well familiar with, and it's used for for inflammatory bowel disease, and dexpramipexole, a medication that has some curious side effects that have been associated with decreasing eosinophil count peripherally. So let's just take a quick peek at those. As I mentioned, etrasimod is an interesting medication that is able to block the sphingosine receptors on the surface of inflammatory as well as resident cells, including endothelial cells. There are multiple types of receptors, and etrasimod is able to selectively target receptors that may limit some of the side effect profiles of this. It is also a once daily oral medication. This selective inhibition may decrease some of the side effect profiles that have been noted with other types of SP1 receptor blockade. And this has been tested in inflammatory bowel disease and been shown to decrease inflammation. The scientific rationale for the use of this medication in eosinophilic esophagitis goes back to some murine studies in which the injection of sphingosine 1 phosphate can lead to eosinophilia in paw pads. You can see the eosinophil increase here. And then in a mouse model of food allergy, inhibition of this receptor was able to decrease the number of mast cells, suggesting it may participate in allergic inflammation. Again, etrasimod is present on the surface of a number of immune cells, both innate as well as acquired. And presently, there has now been a completed phase 2 randomized double-blind placebo-controlled study of etrasimod in adult EOE patients. This was termed the Voyage study. We're waiting anxiously to see what the results of those studies might show as another potential novel therapeutic. I had mentioned dexpramipexole, which is, again, an orally active medication that has been used, interestingly, in phase 3 trials for ALS, was found to decrease peripheral eosinophils, and in a prospective trial in using this for hypereosinophilic syndrome, was shown to decrease the peripheral eosinophilia. And interestingly, in one of those patients, who had eosinophilic esophagitis, was shown to have a decrease in the eosinophilia present here, pre-treatment, post-treatment, and likewise in the small intestine. So suggestion of another potential therapeutic that we'll hope will enter into the study space. Well, this is not a patient who has eosinophilic esophagitis. It is a very interesting patient who has eosinophilic gastritis, a 13-year-old girl who presented with recurrent iron deficiency anemia and abdominal pain, who had Hemocult positive stool. On laboratory studies was found to have anemia, mild anemia that was related to low iron studies. And over the course of her evaluation and trying to understand her more, and as she continued to develop not only the anemia, but also abdominal pain, underwent endoscopy, whose findings are shown here, in which you can see not only the nodularity, but a deep ulceration present with friability and increased numbers of eosinophils in the laminar propria, and her clinical course was quite severe. She had not only pain, but bleeding, anemia, GI perforation. She underwent a variety of different treatments, including elimination diets, systemic and topical steroids. Systemic steroids were successful in inducing remission, but not sustainable over time. 6-MP was used. And so what do we do when we have these challenging patients? We go back to the literature and interestingly found that there was a series of patients who have been treated with vedolizumab for eosinophilic GI disease. And in fact, a patient with Crohn's, a patient with eosinophilic esophagitis, and then in work done again by the Swiss group of patients who had lower tract eosinophilia showed that there was an improvement in the tissue eosinophilia. Well, why might that be the case? In thinking more about the biology of vedolizumab, one can see that eosinophils here have the alpha-4 beta-7 present on as surface receptors, and that may in fact be the reason that blockade of those receptors by vedolizumab may prevent the binding of eosinophils to the epithelium and then extravasation into the tissue space. So this is the potential mechanism of action. We will hope that this could provide another impactful therapy for eosinophilic esophagitis, as well as lower tract eosinophilic diseases. Here's the long-term outcome of that patient. She started on vedolizumab. We were able to wean her steroids. She's off them. She is off her 6-MP, and 4 months later, the gastric nodularity still does persist. You can see that ulcerated place there has healed and the biopsies have normalized. Her abdominal pain is resolved. She overall has done well, but I will give you the most recent update just to say that the interval of dosing has needed to be increased, and we'll chart her course over time. What about the future of eosinophilic esophagitis as it may relate to precision medicine? And I wanted to bring this up because of the increased understanding about the disease, the increased recognition of potential different phenotypes of eosinophilic esophagitis. And this is a great work done by the LASPGHAN group, the LASPGHAN Pediatric EOE Registry, in which they were able to chart the natural history of children over time. I think the symptomatology is not surprising, as shown here on the left-hand side, those endoscopic findings, but they're able to provide us with this really nice summary, similar to what I'd shown you before, in which the symptom complex may change over time, going from vomiting and growth air to dysphagia and food impaction. And does that mean that the disease is changing? Does it mean that there may be more remodeling or problems developing? I don't think we completely know. We may not know this as we increasingly recognize this disease and treat patients earlier. This is work done by Natalie Nguyen, again in our group, in which she teamed with our sex chromosome subspecialists, in which they charted back to look at 667 cases of children who had sex chromosome aneuploidies. They found that there were increased numbers of patients who had a number of these. They presented quite similarly to patients who have EOE, but I bring this up because as a part of your practice, you may start to see patients like this, and perhaps in diving in more fully into what those aneuploidies may either overproduce or underproduce, maybe we'll understand more about the underlying pathogenesis. A very interesting patient who had a novel STAT1 gain of function variant who had eosinophilic esophagitis with a severe form, as you can see this with longitudinal shearing noted on the upper portion. And then very interesting work but done by the Cincinnati group, in what they have now gone on to take the observation that we and others have made that there may be differences in the microbiota of patients who have eosinophilic esophagitis, and how does that translate into patients, their susceptibility or their initiation and perpetuation of disease. And in this study, mouse study, they were able to identify the microbiome. They were able to alter that microbiome based on both antibiotic use as well as fecal microbiome transfer, and then chart the changes in epithelial barrier as well as the development of immune status. And so I bring this up to you to say, again, we're going to learn more about the microbiome and its role in the pathogenesis of disease, thus potentially leading us to these interesting kinds of observations that have been made previously in some children, but in work done by Dr. Zanata, in which H. pylori infection was associated with the decreased odds for EOE in Mexican patients. So could this alteration either help us to understand how antibiotic use or exposure to different types of bacteria may be important to know about? And then finally, this is work, again, done by the Cincinnati group as well as SEGR, the Consortium for Eosinophilic Esophagitis, which a large cohort of patients with eosinophilic esophagitis were analyzed by the eosinophilic diagnostic panel, shown to have a specific mutation associated with T-SPAN12, and T-SPAN12 can promote the deposition of extracellular matrix in the esophagus, leading potentially to more of a fibrotic type of phenotype. So again, understanding who these patients are, there's not likely just one type of EOE, but multiple different types may help us think about targeting treatments, personalizing treatment to those different types of disease, endotypes and phenotypes. And then lastly, can we learn more from other atopic diseases? And this is a really nice summary of the biologic aspects of therapy for eosinophilic esophagitis by Melanie Ruffner, again from the eosinophilic SEGR from our consortium, and Amiko Uchida, in which they compared eosinophilic esophagitis and atopic dermatitis, both having a squamous epithelium and potentially having a similar type of commonalities that may lead to their development. So thinking about this may help us to precisely intervene into their therapies. Well, last, let's touch on the long-term follow-up. I want to bring this back to our patients again in three different realms. And when we think about that picky eater, we certainly think about dietary management in young patients, potentially treating those young patients with dietary management because the parents are able to modify it, because the parents have that child under their umbrella most of the time, to ensure that that treatment can be adhered to, and because this may be a treatment that is based on nutrition and not need the intervention of other types of medical management. And so seems to be a great treatment. I think that also we need to think about if there is access to other expertise, and not only dietitians, but also feeding therapists, because feeding dysfunction is an incredibly common and problematic part of patients who have eosinophilic esophagitis, and it can present at any age, whether that be infants and toddlers, and as in this 3-year-old patient with food refusal, and older age patients, school age patients who may not want to progress in eating specific foods, and then to the older patients who may have a preference for certain foods or a really fear of doing certain things. And I bring this up in particular because of a patient I just saw last week who was an adolescent child, had eosinophilic esophagitis, had also seizure disorders, had a fear of swallowing pills because pills would get stuck that would lead to the loss of seizure control. So here's a real trickle-down effect of how this allergic disease led to problems with other parts of their body. So I wanted to bring this up because of the fact that I think not only is that management of the medical part important, but we also need to have our feeding specialist, if available, participate in patients' care. They can identify compensatory strategies such as chewing their food, using things to wash food down. They can acclimate support to provide support for those patients as they increase their diet, as they develop new tastes, teach how to do things such as pill swallowing. This patient, as soon as we can get that inflammation under control, make sure that the esophageal lumen is the proper size, with the use of a pill esophagram. Also teach them that it is okay and how to swallow pills, be compliant with their medications as well as their diet, and really overall help to build the confidence for the patient as well as the family in taking care of their disease. Thinking back to our 17-year-old patient who had the piece of food stuck, I bring him up because of the very important thinking about the management of food impactions associated with eosinophilic esophagitis. And this was a study that came out quite recently or last year that was a combined work between adult and pediatric investigators in the United States as well as in Europe. A union of Urios, the academic society in Europe, and Tigers in the United States, to think about how are patients managed. And I think no surprise that they're managed by gastroenterologists. This was quite an interesting finding, I think relevant for our practice, in which our adult colleagues typically do not intubate their patients, whereas we do, and whether that is out of it could be for a number of different reasons, but that was one of the quite striking findings comparing the difference between the two. And then the second, I think, was what happens to patients after that impaction and how are they followed up and what type of follow-up should they be. And I think because this was primarily a survey of gastroenterologists, although allergists were involved, most said that they should follow up in an allergy clinic. But in data derived from this group and others, we know that the follow-up care of patients after food impaction is abysmal. And we're not only not identifying patients who have EOE, but we're not caring for them as well as we should afterwards. So this identified an area of need of managing food impaction, patients with EOE after food impaction. All of this has led to this most recent consensus document published by the ASGE. It was a culmination of efforts that occurred last summer in which allergists as well as gastroenterologists sat to talk about what should be the endoscopic approach to patients with eosinophilic esophagitis, and really did emphasize the fact that there needs to be follow-up after food impaction. But again, just as you had suggested in that original article I showed, eosinophilic esophagitis is a chronic disease, needs chronic treatment. The last recommendation on here was probably the one that had some of the biggest discussion, was that in patients with EOE in remission, continued monitoring of symptoms should be performed, and there should be consideration to a follow-up endoscopy with biopsy. There could not be a set time or a set of conditions that would necessarily impact when that should be, but it was clear that patients need to be followed because we learn more, we know more about the disease, we know more about treatments, and we know more about how to proceed with monitoring. So chronic disease means chronic care. We want to induce remission, we want to have follow-up of symptoms, have regular follow-up in our patients, and then consider surveillance endoscopy. I think in our practice, we think about doing a surveillance endoscopy if therapy should change, if symptoms are not responding to previous treatments that they had responded to, if we identify significant complications such as a food impaction or increasing symptoms that maybe lead to stricture formation documented on an esophagram, or periodic following as patients grow older or may undergo life changes such as leaving to go to school or other types of situations. So I'll stop with there just to say thank you so much for allowing me to present to you today. It's an extreme privilege, and just extend my gratitude to my colleagues here in Denver in our Digestive Health Institute, our program and research program, in particular Natalie Nguyen, for providing some of these slides to me, our funding that is shown here, the AGA that has helped in the development of some of these slides, as well as a robust set of slides available at the AGA website if you were wanting to give a talk on this. And finally, my colleagues in the consortium for eosinophilic GI disease research. Thank you so much for this privilege. Hello.
Thank you, Dr. Lifshitz, and for starting my career off. You did that many years ago, so thank you for that. I think it's a very interesting question to think about what the appropriate use of dupilumab will be in the future. I think there are, as I said, a few key patients who it may be very helpful for. And for those patients that we may be able to use dupilumab as a first or second line. I think most of the patients, at least in pediatrics that we've cared for to date, have benefited more from the initial dietary or the use of topical steroids initially, and when either not effective or have more problems with side effects or for other reasons, such as other comorbid allergic diseases, may need to go on to have use of this biologic. But I think as a first approach, probably not likely, perhaps as a step down over time. Yeah, thank you, Mario, for your question. And I think there's a couple different thoughts on this. The first is that in general, we've have the privilege of really personalizing the treatment. And since we're very fortunate to have diet, which has upwards of 70% of a success rate, depending on what form, topical steroids, again, 70 to 90% as a treatment approach. I think all these things are dictated by a number of different factors, including age of the patient, who dietary therapy may be easier to institute, topical steroid therapy, in which patients may be able to tolerate or at least adhere to better as teenagers. And so I don't think there's one preferred approach for patients, but many of it is age dependent, as well as how the patients may be able to adhere to that form of treatment. I think the challenges clearly for diet or adherence. I think for the older teenage patients, again, adherence, to think about how they're able to take those medications. I did not talk about it quite as much, but I don't think that the side effect profile for topical steroids has really been an impediment for us or for our patients with respect to adrenal insufficiency or superficial infections. I think with respect to dietary therapy, the downsides with respect to cost, quality of life, those types of impacts have not been as significant as we might expect.
Dr. Melchizedek Vargas is asking, what other inflammation markers are part of eosinophilia you may see on the biopsies?
Well, a really important question, I think, as we enter into this new era related to eosinophilic esophagitis. It's my sincere hope that over the course of the next decade or so, that we, and even shorter than that, that we start to move away from counting eosinophils. I think, as Dr. Vargas brings up, this is brought with problems with respect to counting, the time, all the different features that may be associated with that. And I think that there has been an eosinophilic esophagitis histology scoring system that has been developed that not only incorporates the numbers of eosinophils, but also their forms, such as aggregates and degranulation, and maybe more importantly, the actual remodeling that occurs in the epithelial space, such as desquamated epithelial cells, the increase in intercellular spaces, the basal zone hyperplasia, and other features. So I think the fact that there are other features associated with eosinophilic esophagitis will be important for us to not only recognize but score, and that over time we may be able to recognize additional things such as laminar propria fibrosis. Work that was just recently published by Garish Hiramath in our consortium identified the fact that laminar propria fibrosis may be associated with thickening of the wall. And so that certainly is another feature that we could look forward to in the future.
Dr. Spolidoro, you may read the questions, because apparently they don't listen to me. Here's another question. You're muted, Jose. Yeah.
Yes. I'm not seeing any other question. Are you seeing?
There is one. Looks like there's one from Dr. Bolanos, who had asked about the number of eosinophils in the colon in pediatric patients. And again, cutting edge question that I think gets to the core of all of the lower eosinophilic GI diseases. And I appreciate that, especially in light of the first slide that I presented today. I think we'll see in the upcoming years more and more attention to this in the consensus document from NASPGHAN, ESPGHAN, and participants, including Dr. Vieira and others on this from Latin America as well as Asia, have come together to think about this within pediatrics. And so I think there can be and will be numbers identified. Interestingly, in the colon, that starts in the cecum as it goes around to the rectum, there are decreasing numbers of eosinophils, 80 to 100 in the cecum, going down to the 30s in the rectosigmoid region. I think one of the important factors that we need to consider going forward does that innate number, because all of the rest of the GI tract outside of the esophagus contains eosinophils, does that number vary according to geography? And I think we're seeing an increasing number of studies that may suggest that's the case. And I think working with your local pathologist to see in patients who have otherwise normal findings what those numbers look like. But upcoming information to be published in that guideline in JPGN, as well as future guidelines in adults. Dr. Juncker, in an asymptomatic patient with an eosinophil count below 15 and with an endoscopy without signs of fibrosis, what is the frequency of control endoscopy? So I'm not quite sure the intent of the question. I anticipate this is the esophagus. Speaking of the esophagus, I think if there is a biopsy obtained of a patient, one of the things that is important to consider always is put the biopsy findings in the context of the reasons the endoscopy was done. So in the 2011 guidelines, there is a statement that someone may have less than 15 eosinophils and still have a diagnosis of eosinophilic esophagitis because of the sampling error. You know, we know that this is a patchy disease. You may not see exactly the findings, although there could be abnormal findings less than a few millimeters away. So I would not dissuade me from making the diagnosis of eosinophilic esophagitis if there were some eosinophils presence in the right clinical context.
There is other question from Bolanos. What do you think about the nodular hyperplasia and GI symptoms related to food allergy?
Well, it's an interesting finding that I don't think has gone through adequate validation yet. Certainly in the colon, when we see lymphonodular hyperplasia that can be associated with food allergic diseases, I think it is probably a signal of increased activity within the colonic mucosa related potentially to food allergy. And I would use this as another marker and a potential identified lesion that could be associated with food allergy in the right context. So if we're doing a colonoscopy in a patient who seems to have persistent reactions to certain foods, wondering whether that may be associated with some type of GI involvement, it would be supportive to me of a potential non-IgE mediated form of food allergy, potentially non-IgE, unlikely to be IgE mediated food allergy though.
About that paper that you showed regarding comparing 6 food exclusion and one, the same results, what's the strategy to choose which food would be this one?
Well, I think, you know, this was really a very exciting finding to us for several reasons. I think it really actually was developed with our patient advocates to say, can we in fact go simpler? Can we just go first to one food elimination diet? And I think these results suggest that's the case. You don't have to maybe go such a high degree of stringency initially and just try the dairy elimination first for this disease. And that may make life potentially more simple in looking at dietary elimination. I think the second thing it pointed out was the practicalities of the diet elimination. You know, the original findings were up to 70% of patients responded, but in a multi-site study, it went down to 34%. So effective, but perhaps not as widespread in its impact.
Mario Vieira has another question. For those patients responsive to any forms of treatment, is it impossible to treatment temporarily or to switch to another form of treatment?
Yeah, you know, I think that Mario brings up the important point of what is going to be the strategy for maintenance treatment of patients with eosinophilic esophagitis. I think there has been suggestion, can you just treat on demand? I think we don't know enough about the long-term implications of intermittent eosinophilia and how that may relate to fibrosis and stricture formation. So I think chronic therapy is important, but I think that switching between therapies, if you found that it both decreases symptoms as well as maintains the integrity of the epithelium and decreasing the inflammation certainly is a reasonable approach, especially as patients age, so that patients who are younger may be more readily accessible with respect to diet, and as they get older, perhaps topical steroids make sense.
We have no more questions. I don't know, Rodrigo, would you like to ask something?
No, it's okay. Thanks.
So I think that we can say thank you very much for excellent presentation and also to be with us here to answer these questions. And I will pass the word for Dr. Hanvo to say the last words, and we can finish our activity.
So again, thank you very much, Dr. Glen Furuta, for your outstanding presentations and very exciting discussions. And thank you for participating. And we hope we will enjoy the next webinar next Thursday.
Thank you very much. Thanks for the privilege of being here. Good to see everyone. Be safe.
Thank you, Glenn.
Okay, bye-bye now.
Bye. Bye, thanks.